2 cents. Do we have an AED in the building?
No.
Useless grant.
Actually, wait, sorry. No, we do. Down the hall.
I'll say there should be one.
We do have one down the hall.
Okay.
Yes. A shared one. So it saved me some money. What's up, guys? We got some peeps. We anticipate there might not be as much attendance because the world is open again. So we will still post this on YouTube for people to watch. I think it's still good to do, and then we need feedback on if there's a different day to do. We could do a Saturday or Sunday.
Mm-hmm.
Going into the future, maybe only doing one a week. So let us know, just because we want to keep it up, but maybe not 3 times a week, just because I got a lot of work to do.
So do you guys.
Roz, yeah, you got a lot of work to do. You
More
have
bang for your
lunches
buck.
to eat and stuff, so we'll get right into it. We'll dive right into it. I'm going to line up the phone with the computer, and we'll talk through it. If there's any questions, if people come in later, just give us a shout, even though they just didn't hear that. They can't give us a shout because they don't know what I just said.
Oh
No. We might have a physio yogi coming in next week. Eh?
Cool.
Physio yogi. Okay. We have mastering the Achilles tendon.
Is that good for glare?
I think I should probably watch people vomit while watching this. Oh man, the camera's moving. So there's that. Mastering the Achilles tendon. And I can go to the next slide. And Rob, you can take it away if you want, or
Sure, yeah. Of course, if anyone has questions, let me know. It's going to be kind of different levels today. Some basic stuff, some more in-depth stuff. So if you learn too much, I apologize. And if you don't learn enough, we'll give you your money back for the presentation. So tendons, we all know about tendons. Basically, a tendon is it's a connective tissue that connects a muscle to a bone, whereas a ligament connects a bone to a bone. They kind of look the same if you look at one. They're kind of white and shiny, collagen more or less. They're very strong, and their fibers are kind of oriented kind of longitudinally, so they all kind of run the same direction from end to end, which gives them a lot of resistance to tension. Its job is going to be transmitting forces from muscles to bones. Simply speaking, they also have a kind of a role in energy storage. So with you can kind of picture jumping, running. They do have a little bit of elastin, so a little bit of elasticity in them too. So they can kind of help with energy storage and release to give you a little bit of maybe a kind of a trampoline effect in those cases. And they're also important for kind of your fine motor stuff. If you picture the tendons that run from your forearm down into your hand, for example, they're also going to give you lots that fine motor control that you wouldn't be able to achieve otherwise. Each muscle is going to... that's okay.
My bad.
Each muscle's got 2 tendons, one at either end, which makes sense. A muscle's going to connect one bone to another bone for the most part, so it's going to have a tendon both at the origin, which is basically kind of the proximal, closer to the head side of the muscle, and the insertion, which is distal.
And then we got the Achilles tendon was shared between the gastrocnemius and soleus, so known as the triceps surae. 3 different muscles. Well, the gastroc is 1, but sometimes considered 2 because you have the medial and lateral heads. But the form is a triceps surae, connects to the calcaneal bone. That's where it inserts to. There's a deep bursa that permits movement of skin over the tendon. This is to decrease friction. Things glide smoothly with that. So you have function, 93% of total plantar flexion force, so that's kind of pointing your toes down, so doing a heel raise. So 93% of that comes from the Achilles tendon, or gets transmitted through it. Elasticity, like Rob mentioned, recoil plus shock absorbance of foot, and it is the largest and strongest tendon in the body.
Would you say it's as epic as Achilles himself?
Yes,
There
I
you
would
go.
say so. In the movie and in real life.
Yeah.
Real life harder to know because
Shout out to Brad Pitt.
historians. Yeah, he looked good. I mean, He looked great.
He still looks good, really.
Yeah, he still looks damn. I wish.
Anyways, what were we talking about?
I don't know. Achilles.
Yes. So anyways, this is like a little more Achilles anatomy right here. Kind of like that posterior view, and you can see those muscles that Sonny was talking about. The gastrocs here being cut, but the gastrocs is that kind of that more superficial, just under the skin muscle in the calf. It's got the two heads to it, and you can see that on some people who are quite lean. It'll kind of have the line down the middle. You'll be able to see the two sides. The deeper muscle there is the soleus, so that's underneath the gastrocs, and then the plantaris is kind of a little small muscle there that helps out as well. The soleus, it's deeper, and it doesn't cross the knee joint at the upper end the same way that the gastrocs does. So that just has implications for how that muscle functions. It'll have a little bit more of a role when you're working kind of a plantar flexion or a toe pointing with a bent knee, whereas the soleus is going to be a little more of a significant contributor with a straight knee. In our picture on the left side there, I like this one because it sort of shows how the Achilles kind of wraps around behind the heel bone, so kind of behind that calcaneus there, which is important in a lot of Achilles tendinopathies. Kind of that wrapping. You can kind of imagine that the underside of the Achilles tendon is going to have a little bit of compression against the bone back there, and especially when the foot is dorsiflexed, or when the kind of the top of the foot is brought towards the shin, and in this picture the rest of the foot would be going off in this direction. So you can kind of imagine that as that kind of turns upward, there might be some compressive force on the undersurface of the Achilles there.
So injury, repetitive overuse is a common cause of this. So not being traumatic, so just atraumatic, so just kind of using it over and over again in sport and kind of breaking it down. So the repetitive overuse mainly occurs in athletes or exercise related. So if you're pretty active, injury rates are 6 to 18% for athletic populations. So pretty high, considering, on both sides of it, 6 to 18% is quite a bit. 55 to 65% of injuries is diagnosed as Achilles tendinopathy. 25 to 35% are insertional issues. So kind of where that bursa that Rob was pointing at, or an insertional tendinopathy, so where it goes into the calcaneus. Remaining are diagnosed as partial tears or complete ruptures, and quite a few times the complete ruptures can be undiagnosed. It might not behave like a true rupture. And 60 to 75% of ruptures occur in sporting activities, which is very interesting, basketball, soccer. So quite a high prevalence in sport. I've seen it happen in workplaces. So I've had WCB claims, for example, with complete ruptures. Not very common, but I've had it before. So for people who are watching that don't play sports, it can still happen to you, but less likely. So if you play sports, well, be careful.
Yeah, don't do it.
Do what we're going to talk about today. So doing what Rob's going to show you guys and talk about is going to be important. So yeah, injury rates can be high. And then this is just a slide from a previous talk that we had with Rehab, talking about tendinopathy. So I thought I'd just insert it so you can see the tendinopathy, the tendon collagen fiber destruction and disorganized repair. So you can see the damage to the tendon here. Just a nice slide to see what it looks like zoomed in. Not like it's cut. It's not like it's cut. It's more frayed. So the fibers aren't straight anymore. And then there's some couple injuries here. You have inflammation here with the thunderbolts, because that's what happens in inflammation. You have two forks that have spread the skin, seeing it.
Also a common cause of injury.
Also common. If you did that, that's really bad, really bad. Your tendon might be intact, but your skin won't. You have this, which is a rupture here, so you can see a complete disconnect. Just, again, very simple images to follow. Referral pain, this is a gastroc, and you can see referral pain in the gastroc is in these areas. So differentiating between an Achilles issue and a gastroc or soleus issue, you typically have pain up a little bit higher towards the origin, but you can see with the patterns, it can go down into the Achilles area and the bottom of the foot, and then the soleus more often is a little bit lower. So you can get a misdiagnosis or something like that. Like, I mean, if you treat one correctly, you'll treat both correctly because you're still working on the soleus and gastroc when you're treating the Achilles. But I just wanted to show the referral patterns. It's quite diverse. Like you have gastroc here, huge area, soleus a little bit shorter and a little bit more specific. Any comments to add about those?
No, I think that's beautiful.
I love referral patterns. I love it. And I'll let you.
Yeah,
I
love this slide so much. So yeah, Sunny had talked about like a few slides back. If we jumped back here to this guy, and you can kind of see how those tendon fibers look different. So let's say you're a person who's had kind of this like chronic Achilles pain, maybe for, well, anything at all, days, weeks, months, years, all are possible. Typically it is going to be like a portion of that tendon that has become sort of like disorganized like this. So different terms that we use, so like tendinopathy generally is going to describe sort of the clinical diagnosis. So like pain with activity, pain to kind of poke and palpate the area, and pain with like strength or kind of provocative stretch tests, those types of things. That's going to be tendinopathy, is kind of more like symptom driven. Itis is always going to mean inflammation, so tendinitis is describing a tendon inflammation. Tendinosis with an OSIS at the end, that's another term that's like used a lot now. And osis is it's kind of a descriptor of the tissue changes that happen in the tendon. So if you were to look at sort of this disorganized area here versus kind of our nice straight white area there with an ultrasound, you might see something like this. So on our left side here, the top and bottom image, those are both from a healthy Achilles tendon. So you can kind of like, if you kind of think of like a bundle of spaghetti noodles, they're all running the same direction, they're all kind of the same length, the same shape, they pack together really nicely. You can see this is kind of this would be sort of the view looking at the back of the Achilles. And if you were to like cut the Achilles and look at it from kind of the top down, this is kind of how you'd see it. Or if you were holding your spaghetti noodles in your hands, that bottom image would be the side-on view of the spaghetti noodles, and the top image would be if you kind of turned that bundle of spaghetti noodles towards yourself. So you can see that, like our spaghetti noodles, our healthy tendon, we have these nice long uniform collagen fibers. They're nice and tightly packed together. And you can imagine that functionally that's going to be really efficient for resisting kind of that pull from both ends of the tendon. And then on the right-hand side here, so as far as like imaging goes, this is kind of what we would expect to see with a tendinosis, where we sort of have that like tissue breakdown. We're going to end up with a lot more water content in a tendon when there's tendinosis going on. There's an increase in these kind of GAG cells that attract water. They exist in the body anyways for like cushioning and lubrication purposes, but with tendinopathy, we get more of those in kind of the substance between cells. So it's going to attract water into the tendon. That's going to make the tendon like larger. It's going to give it a bigger cross-sectional area. So it's going to make the tendon bigger, but you can kind of appreciate that because of the other structural changes, like our nice spaghetti noodles have turned into, I don't know, macaroni noodles, or like those little Lipton soup packets with a little.
Oh yeah, those really, yeah.
That's
the
chicken's
noodle soups.
Yeah, those ones. Yeah. That's what this reminds me of. Versus like our nice spaghetti noodles.
Yes.
So with our Lipton soup noodles, I mean, you can kind of tell like there's not much organization there. If you were to sort of like pull on that tissue from both ends, it's not going to do a good job of kind of resisting that longitudinal tension. And yeah, those are kind of the changes you're going to see with the tendinosis anyways. Yeah.
Why did this happen? This happened.
Well, I can keep talking in the meantime. Anyways.
Yeah,
We'll
keep
get
talking.
to the next slide here.
I will.
So with Achilles issues, those are some of the structural changes that we'll see. But you can sort of like break up kind of like findings. Like you might see symptoms, you might see functional changes, and you might see tissue changes. And you might get issues with one at a time rather than seeing all three at once. So as with lots of different kind of like chronic tendinopathies, usually the onset is going to be kind of a gradual buildup of tendon dysfunction. So usually you're gonna, so usually what's gonna happen is you're gonna be like loading your tendon too much or loading it in a weird way, or something's gonna be happening that's causing tendon compression, and we end up with this kind of unhealthy tendon. Am I on the screen there now?
You are, yes.
So you end up with kind of this unhealthy tendon. It's not getting the kind of loads that it craves, and then you start to get these structural changes that we saw on the slide, where instead of these nice kind of longitudinally oriented fibers, things become sort of disorganized. And this is going to happen gradually over time, kind of weeks to months. You can think of it that way. And while this is going on, you may or may not have pain at the same time. But generally, once the tissue kind of hits like a certain level of degradation, then the pain is going to come on. So for instance, if your pain starts on May 10th, you probably were having some of these gradual tissue changes, maybe since like mid-March or mid-April. So that's important too if you're looking at kind of addressing the cause of your injury, because people who kind of get pain with one workout, they might attribute it to something they did on that day, if that's May 10th in this example. But it's important to kind of look back at different things, footwear changes, like occupational changes, training changes if we're talking about athletes, that happened over the previous months, because that's usually where you're going to find, I guess, more evidence about the cause of the injury and evidence about what you can change to kind of effectively manage it. So that's an example where you might get those structural changes that kind of precede the pain or the symptomatic changes. And on the recovery kind of side of the curve, you'll kind of see the same thing. So often, once you start to be successful with rehab, kind of like managing the person's pain, activity modification, starting to build those exercises, usually that pain is going to go away, maybe like 6 to 8 weeks, 8 to 12 weeks, somewhere in that span. But if you were to do a diagnostic ultrasound at that point, very often those tissue changes are still going to be showing that kind of like that hypertrophy or that kind of large, watery, disorganized tendon, to some extent at least, maybe not the same extent as at the onset of pain. But typically the tendon structure is going to recover more slowly, kind of over like at least a year, whereas the pain might go away quicker. So again, you kind of have that disconnect between what's going on structurally and what's going on symptomatically. That's important to keep in mind, because as the pain goes away, whether it's with rehab or rest, a lot of athletes or people will kind of go back to their regular activity pattern that caused the issues in the first place. And since we don't have that structure that's fully healed, you're going to end up flaring it up again. What happens in kind of those cases, typically you're going to have, someone will feel better. Let's say like a runner, for example, might go back to his or her previous training program. This time the symptoms come on quicker because we're kind of starting with that dysfunctional tendon. And again, symptoms, you're going to have like pain with activity. And
I fixed the problem by restarting my computer, so we're good.
Perfect.
I'm sorry.
There'll be something else to look at.
I don't know what's happening with my computer. I hope it's not dying. I don't have the residual.
Sure, I'll challenge it right away and we'll see if we can. Oh yeah, okay.
It has been challenged. It's happened once before, so we'll call Apple and complain.
Let's see if I might be right at the end here. Anyways, you kind of get into this pattern where you go back to play too soon, the injury comes on. Here it is. So the injury comes on more quickly the second time, so you rest connection. Oh, it's back, okay. So yeah, each time you kind of return to play, the injury comes on more quickly, so you end up resting more. When you rest, the tissue is getting weaker and softer. And yeah, with each subsequent return to sport, you're just doing more damage until eventually, like you can't get out of bed in the morning, or you can't go down the stairs in the morning, and things have just become really extreme at that point. And this slide here sort of demonstrates that a little bit. So this is kind of like an injury risk versus applied loads graph. So on the on the horizontal axis here, if we look at kind of a runner, it's a simple example. This could be like number of kilometers per week. So if you're doing like very few kilometers per week, then tissue's not going to be getting any kind of positive adaptation going on. It's going to be getting softer and weaker. But if you overdo it, if you're way too high on the activity graph, and again, so with the runner, maybe you progress your training too quickly, it's going to be too much load, the tendon can't handle it, so it's going to break down. Homeostasis, that's where like most of us are on a day-to-day basis. Tissue turnover is kind of equal, so the body's breaking down tendon and rebuilding tendon at the same rate. And then where we want to get for rehab is kind of this adaptive homeostasis, as it's called on the graph here. where we're kind of challenging the tendon enough and in the right ways that it's able to become stronger, better organized, and more functional, but without overloading it. So that's kind of, I think, where people who try to manage these things on their own run into issues, is they end up either pushing it too hard. If you think of like maybe the competitive athlete, that kind of thing, like the no pain, no gain mentality, like push through the pain, get through it, that kind of thing, which you can see is going to lead to tissue dysfunction at this end. Or you might have like kind of I don't want to say your average Joe, maybe your non-athlete who gets a bit of pain and they're like, whoa, I'm getting off my feet for a couple of weeks here.
Yeah. And
then I'll go back to my activity. And then while they're fully resting, they're not doing everything they can to kind of get that tendon back to health. So yeah.
That's cool. I like that. I like the graphs.
Yeah.
And which should I go to next?
Well, maybe hop back a few slides.
Oh, are you kidding me? I don't know what's
Will the
going
back arrow work?
Sorry?
Oh.
No,
Oh no.
If you continue talking to the camera.
Hey, sounds good, yeah. We'll talk about something else.
I think this computer is dying. That's the real issue.
Yeah, so anyways, we talked a little bit about how like symptoms. Here, I'll do selfie mode here. There we go.
Yeah.
So we talked a little bit about how the symptoms and the structure don't always, just let me know when it's ready there.
Yeah.
They don't always kind of go together. You can have one without the other. And I mentioned like function too, which can also kind of do its own thing sometimes, independently of structure and symptoms. So when they look at, let's use like a runner again. That's a simple example. If you're kind of like tracking your training times over time, let's say again, like May 10th, you develop this Achilles pain. A lot of the time, if you look back, you'll kind of see that your training times have been like not as good as you would expect leading up to that. That's even though you may have had like no pain or no other signs of injury. That can be an example where the tendon, it's kind of losing its function. Again, there may have been like structural changes going on over that time. So that tendon may have kind of like, again, lost kind of its like spaghetti orientation, kind of turned into its like macaroni elbow noodle kind of configuration. And when it's set up that way, it's not going to be as effective as kind of like an elastic tissue to provide like rebounding for running, for example. Or if you're like a jumping athlete, you may have like lost some power in that leg. And so anyways, those would be sort of like the functional changes that you might see before even the onset of like pain, for example, or before a diagnostic ultrasound ever picks up the structural stuff. And that's kind of leading up to the injury. And again, if we look at kind of the other side, post-injury, there can also be like a disconnect there. So if you look at people who have had like severe Achilles tendinopathies or even like Achilles ruptures, let's say like 2 or 3 years back, so now they don't have symptoms, they've kind of gone back to their full activity, they'll often still have, like for example, if you look at runners post-Achilles injury, they'll often like make little changes to offload that affected side a little bit. So they may be a little bit asymmetrical. So loading the kind of the uninjured side a bit more than the previously injured side. And they'll also make subtle changes to their running mechanics that can they can transfer some of the kind of like the load acceptance onto the knee sometimes, rather than the foot and ankle, which of course is kind of more that Achilles region. So even though in those cases the athlete probably doesn't perceive that they're running differently, but if you really go crazy with like markers and video analysis, you can kind of pick out those changes, and studies have shown those to be a real thing that happens in runners post-injury. So in that case, the symptoms may have resolved, and potentially the structural stuff may even kind of be on the way down, but you might still kind of see those functional changes.
We're good.
So we're good, okay. So anyways, we talked a little bit about structure there, a little bit about function, and a little bit about symptoms. And again, you can have one without the other, but of course you can have all three as well.
And I'm going to go back to the other. Sorry guys, I don't know what's wrong with my computer. This is the first time it's a computer issue. I'm just going to leave it like this. I'm not going to go into full mode. Is this the slide you want, Rob?
Yeah, that's a good slide. I can talk about this one for a minute.
Yeah, I'm not going to open up the slideshow because.
Sure, yeah, no, that's good. So, so this is a really interesting slide, and it's looking at, so if we're looking at a healthy tendon with no injury going on, there's always going to be a little bit of tissue breakdown happening and a little bit of kind of tissue formation, a little bit of tissue like synthesis happening. And if again we think back to that curved graph where we had that kind of homeostasis chunk in the middle where the turnover is about equal, the tendon's not getting any stronger, it's not getting any weaker. The new tendon cells kind of match the ones that are dying and getting cleaned up, and things are just kind of staying where they're at. We know, of course, that exercise is going to change what's going on there. So this graph is showing the changes in tissue breakdown and in tissue regeneration after a really heavy workout. This one I think was like a 30-kilometer run, so quite a big run. So the top curve here, this is new tissue growth. So you can see that like pretty soon after the workout, the body is kicking it into high gear, laying down a whole bunch of new collagen in the tendon. The line at the bottom here though is tissue like degradation, so kind of like breakdown of the tissues. And you can see that again, after this heavy workout, the body is getting even busier breaking down tissues. And the more subtle line in the middle there that you can see kind of like dipping below that horizontal axis and then kind of gradually coming up above it, that's going to be kind of like your net collagen. So if you take your collagen pre-workout and you subtract the collagen that's being broken down, add the collagen that's being added in, it's going to be kind of like the total sum. So you can see that in this graph, it's up to about maybe 24 or 30 hours. There's overall like less collagen than there was pre-workout. All the way up to about 72 hours where things sort of level out. So this is important for rehab because we can imagine that if we're kind of like giving that Achilles tendon a heavy workout on Monday, we wouldn't necessarily want to go and work it out heavily again on Tuesday or even on Wednesday in some cases because it hasn't kind of gotten back to that kind of that like metabolic neutral where it needs to be. So anyways, the bottom line is it can take 2 or 3 days for the tendon to recover from a heavy workout. Yeah, that's the one thing to take from this slide is that it's not always good to give the tendon a heavy workout on every subsequent day. But with that being said, like most Achilles programs, they will have you working out like every single day, and that's appropriate. But you're just gonna have to sort of like tailor the intensity of your workouts to kind of match the desired like recovery cycle there too. So you might have exercises like the one on the top left here, which is simply like laying or sitting, and you're just pushing the foot up and down, so sort of a circulation exercise, or even something like a two-footed calf raise, which is top and center there. And depending on where you're at in the recovery, those might be ones you can do every single day that won't cause like enough tissue damage or remodeling to kind of require a workout to require like a rest day afterwards. But if you're doing heavier workouts, then you want to give it like 2 or 3 days to sort of recover from that. And on those recovery days, you can still be doing stuff like walking, foot and ankle pumping, some of the lighter stuff too. Yeah, anything to add to that?
No. Those are all familiar with.
Yeah. So these slides here, they're all just like different examples of like protocols for return to sport after an Achilles injury. So this one is kind of like a runner one. Oh. This one's a bit more detailed. It's got 4 phases, recommended timelines, that type of thing. This one again is a bit more general, working someone through 4 stages. But yeah, like, so they're all a bit different, of course, but basically they all kind of follow like the same sequence. So like after an Achilles injury, or like once your symptoms come on with your Achilles tendinopathy or tendinitis or tendinosis or whatever you want to call it, you do want to have like a little bit of rest initially. People use different like rules of thumb, I think, to kind of know like when it's appropriate to start exercises. Mm-hmm. Some people will say that that a patient needs to have like maybe pain levels that are like 2 out of 10 or less with like their activities of daily living before adding exercise. But it depends on the person, like everyone's pain scale is different. And if someone's been dealing with the injury for a very long time, they might need like more aggressive rehab to kind of break them out of that cycle. But that's where you want to start anyways, is kind of ideally getting that resting pain down to a manageable level. Yeah, usually from there, so I don't know, when I talk about tendons, if you see my like the running presentations, like I always think about the tendon as it has to deal with like high, like kind of peak forces. So that's kind of the max force the tendon has to kind of resist at a given time, I guess. So in runners, that can be really high. It can be like 6 to 12 times body weight, which is pretty big. I'm like 160 pounds, so multiply that by 12. That's like 1,800 pounds or something. A little
Sounds
bit more than
about
that.
right, yeah.
It's a lot of pounds.
That's a lot of pounds.
Yeah. So, and anyways, that's kind of your peak force. So it's important. So after the rest phase, then I'm thinking like retraining this peak loading. So usually the rehab is going to start with something a bit lighter to get a person sort of accustomed to working out again. That could be something like our toe pointing exercise here to stimulate circulation in the Achilles. It could be something like if the 2-footed calf raise is too aggressive, you could also do like bottom middle here is a seated calf raise. So that one you're simply sitting in a chair, pushing up on your toes.
Yeah.
So it's working the muscle in a similar way, but without body weight through it. If you think back the anatomy of like the soleus versus the gastrocs again, you can kind of imagine that might be more of a kind of a soleus focused exercise, whereas a standing exercise, you'd be any more gastrocs. The sitting version, you can also like add weight to your knees. So you can put a weight plate on there, or like put a kid on there, or put your wife on there, your buddy.
Your buddy.
Not until, social distancing.
Yes.
Do that, but you know what I mean? You can load it up that way too. So you're going to start with like maybe more of like kind of an endurance focus. So maybe like more repetitions with less weight. But as soon as you can, you want to be like starting to load the tendon heavy a little bit, because that's what it's going to respond better to. So when able to, you want to be kind of like either progressing to full body weight. Exercise in the top right corner here is a single leg calf raise. So similar to the double leg, but with 1 foot. So you can kind of imagine that's going to just double the weight through the foot. It's going to be your full body weight on your affected side rather than half and half if you're up on both toes. You might progress that one too, depending on the kind of tendinopathy you have, by working off the edge of a step. Like personally, I won't do these ones with a person who has like a tendinopathy right like at the insertion on the calcaneus, because here we'll scroll, let the suspense build a little bit. Again, if you sort of think back to the anatomy here, like a lot of the times those insertional tendinopathies like at the calcaneus will kind of be a result of like pressure being formed between the underside of the Achilles and the calcaneus. So as the foot goes into like full dorsiflexion off the edge of a step, there's going to be a lot of compression generated back there, which you don't necessarily want with an insertional tendinopathy. If the tendinopathy is higher up the Achilles, which we'll call like a mid portion sometimes, if it's further away from that insertion on the heel bone, then you're probably going to get away with these exercises earlier. But you're always going to sort of want to use like pain as a guide a little bit. And again, I think everyone sort of has their own like rules of thumb there. But one easy one is just keeping your pain below like a 5 out of 10. Mm-hmm. So I would tell a person if you're in kind of a 3 to 4, that's good. That means that you're kind of generating enough load that you're going to be causing some positive adaptive changes. But if you get higher than that, if you're like a 5 or a 6 plus, then you want to like ease it off a little bit. Some people will find that they have more pain. Maybe they're okay during the exercise or during their run or whatever, but that evening their pain gets really high, or the next morning their pain is really high. So it can be good also to kind of use that same rule, like if your pain gets above a 5 the night after exercising or the morning after exercising, then again you want to be kind of making a change that doesn't happen. One more kind of rule that I'll use sometimes is just that you don't want the pain to be greater like week over week. So it's going to fluctuate day to day without a doubt, but generally speaking, if after a week your pain levels are higher than they were the week before, you may want to dial the exercises back a little bit.
I like what you mentioned here. So to getting tendon injury, isometric strength. So obviously starting, you do concentric and then eccentric and then functional strength, I assume, right?
Yeah, something like that, exactly.
I like this because this kind of stepwise progression is kind of how I like to treat everything pretty much. Like
absolutely,
tendinous, like it's, I mean, ligamentous, similar type of deal. Like you can even like If you think about balance, you can work that into strength as well. We talked about balance and proprioception. So I like this is like a super clean way. I like this one a lot because it shows rehab in general, how you should progress and being pain-free in each step. So yeah, I like that slide a lot.
Yeah,
I like all the slides, but it's just super clean it really shows people. I'm going to use it with patients, but it just shows a good I responded to an athlete last night, an email, and I said phase 1, 2, 3, 4, 5, or 4 phases, and it's because of things like this that's made me treat like that, and then reading out the phases in my head now, I'm like, that's pretty much the same as that. What is the timeline for each stage? I would say, I can comment on it. I'd say until you're pain-free. So if you're doing isometric work for like a week, let's say, and then you start noticing no strain the next day, no issues, no pain, then I'd say progress to the next stage. If there's no instability, progress. So there's no set time. I'd say isometric work maybe a week or two in the acute phase, and then move on from there. But if you notice exacerbations, you got to drop down a stage. Like if you do functional strength, for instance, and you notice a 5 out of 10 pain and it's increasing, then you need to step back and go back into the strength. The question is, so patient specific? Yes, patient specific, injury specific. Anything you want to shed light on?
As far as like timing goes?
Yeah.
Yeah, I think there's other protocols like this one here. I think it's from it's an article maybe 10 years old now, but it has times for each stage. But I think it's important not to get hung up on those because, number one, everyone's tissue is so different, right? If you're dealing with a 22-year-old athlete versus a 56-year-old overweight smoker, you can't compare the two, right?
No.
They're gonna have more different than they have in common as far as tissue quality goes, and the recovery is going to be so different. But yeah, there are protocols like this one that will give you some guidelines for timing. But yeah, totally. I think it's more useful to kind of use and understand a more simple template like this one, or this one here doesn't have the nice staircase to it, but again, it's kind of your stage 1 isometrics, stage 2 working into the, like Sunny mentioned, that could be your concentrics, your eccentrics, the heavy slow, HSR is heavy slow resistance. So kind of shifting more from an endurance to a strength focus, for example. If you're thinking sets and reps, you have to be going heavier weight for fewer repetitions, but doing more sets. And then working from there up into your, on here it says energy storage and release. That's going to be plyometric training. So that could be bouncing on 1 foot, bouncing on 2 feet, doing box jumps, those kinds of things. And for this one, I know it recommends moving on to that once you kind of plateaued with your strength. So you're doing a good amount of load, it's not flaring you at all, and you're kind of getting to the point where progression is kind of petering a little bit. Then you bump it up to the next stage. And then again on this one, the last one here it's kind of your return to sport, which if we go back to here, return to play, those obviously mean the same thing. And on that other one we were just at, it also mentions that it's good to kind of keep up the training even once symptoms have kind of gone away. Yeah. And we talked about that too a few minutes ago with how the pain will usually disappear before the tissue is back to its back to 100%. So even when the pain's gone, and if you're performing well with your activity or your job or just your life, you want to keep working on, in that example, they want you working on the heavy slow resisted stuff once a week and the plyometric stuff once a week, because there's still going to be tissue changes going on and functional improvements, even when the pain's gone.
Very good points. Yeah, timelines, it's always good to have timelines, but you can't think of a general timeline for people because everyone's different, injury specific, patient specific. If it's an Achilles rupture, for instance, then yeah, there's timelines there because it's ruptured. There's a very serious issue, right? So, sorry, I'm straightening out my tripod here. So
I think it's also good because it kind of makes you focus on the what needs to get done in each stage.
Yeah.
Versus stage 1 is 4 weeks, so if I'm just waiting it out until I get to stage 2, which isn't how it works. So yeah, it's better to think of it as being, once I can do this this load for this many reps number of days, then I can move on to the next stage. It's more motivating, I think.
Yeah, I'd say if it's a minor strain or tendinopathy, it's probably looking at 4 to 6 weeks. But then it depends on the sport, because if you're competitive, then you might not take the 4 to 6 weeks to be off activity, right? So if it's more moderate, like 6 to 10 weeks. Ruptures, again, have their own specific protocols. Like there's an actual PDF you could download. And each surgeon or orthopedic specialist has their own recommendations. So I think it's best to understand the stages. That way you can progress faster if your pain's going down. So then you're not... The stages are good because it slows people down that are moving too quick, and it might speed people up that might be moving too slow. So do you progress intensity or volume first for each stage?
Usually I would like progress volume first. Mm-hmm. So let's say I have someone working on, let's say it's like kind of like seated, let's say it's like our seated like calf raise here. That's a really simple exercise. I'm just doing it with like kind of, I don't know, body weight, but really it's just the weight of my lower legs here. To start with. If I'm starting a person off with like, let's say 3 sets of 10, I would probably have them work up to like 3 15s and then add weight to it and drop the volume back. So if I'm adding like a 10-pound weight plate, I might drop them back to like 3 8s or something like that. Make sure they can handle it. Again, I'm looking for like kind of that 5 out of 10 pain during the exercise, evening after and morning after. And if that's like well tolerated, then kind of building the reps up again.
Yeah, that's, increase weight, drop reps, and go back up.
Yeah.
Yeah, if things are stable and not painful, then yes, progress. Like the 24-hour to 48-hour picture that we always describe is very important, right? If it's sore, like a 3 out of 10 for 48 hours after and it's decreasing, then that's probably a good work. Like if you're in the isometric stage and you're doing exercise and the next day it hurts like a 3 4 out of 10, and then 48 hours post, it kind of goes down to minimal, then that's where you want to be. Then you don't progress until the next day you don't feel anything really, or very minor. So yes, you want some soreness after exercise. It's going to be normal. It's better if it's muscle soreness over the tendon soreness, but that's another thing, is educating people that certain pain is okay.
Yeah, and that kind of like leads back to that U-shaped curve we talked about, where if you're loading it too much, you're breaking tissue down. If you're loading it not enough, tissue's breaking down. You have to kind of find that sweet spot.
Yeah, and I think that's these two, this stepwise progression and that graph together are really good to show people of like the benefits of these things speeding people up that might be too slow, or slowing people down. That's always the trickiest part, is to find people that are going to be realistic with themselves and be honest with them. Yourself, honesty is very difficult, because you'll trick yourself and be like, I don't feel that much pain, but you do. And then you're like, let's just progress fast. I do it all the time. I do it on a weekly basis.
And a bit of like journaling can be useful there too. Like if you're using like, you don't want to get too pain focused, of course, but if you can keep like a little pain journal, like you can also use it as like a did my exercises journal. Because if you're reporting on pain during exercise, it means you did your exercise. So if someone's like the kind of person who comes in after 2 weeks and you haven't seen them and they don't know their exercises they were supposed to do, or they lost their sheet, or they whatever, like that's a good tool to kind of get them like self-reflecting on what they're doing and what they're feeling too.
Yeah. And you don't have to quiz people when you're questioning if your patient's doing their work. You're like, hey, let's see all the exercises, and there's your exam.
Yeah, that's right.
So yeah, pain journal is good. So anything else to add, Rob? We can leave the floor open we'll give you guys a couple minutes to type out any questions if you want. This will be questions. For the YouTube people that watch this in the future. We'll have this uploaded, and you can email us at info@pursuitofmotion.com. It will be on our profile as well on YouTube. You can always send us an email in the future time. So, and Shane has joined. Hello, Shane. You missed everything. Sorry, too bad.
Check us out on YouTube.
Check us out on YouTube. So yes, email us questions. That's a great talk. And I think people just have to be realistic with themselves and progress as able, and get assessed to know how severe your injury could be. Don't want to be able, once you're injured, you're more likely to get injured further, and you don't want to rupture this thing.
Mm-hmm. And it's not the kind of thing that necessarily goes away over time either.
Yeah.
For most people.
Achilles ruptures I've treated many times. takes a long time. Like pain wise, yes, it dissipates, but to get the strength back, takes
And performance too, right? Like, yeah, it's never the same after.
No, yeah, Achilles. I've seen a few, and they take time. They get better, but they take time. So yeah. And then we'll leave the floor another minute for questions, and then we can wrap it up. Unless Rob has anything else to say.
Nothing else.
No.
Always more, but I mean, I think it's a natural.
These days are good because I don't have to do too much. But announcements next week. We will do a couple more topics. We're going to try to get someone in on doing a talk on physio and yoga. So physio yogi. I think that's a clinic on the south side, but she's not from that clinic, from Calgary. So, and she's also a climber too. So we might do climber collaboration. I can get some pegs in the wall and try to climb it, scale the building, and see what happens. We'll do an outdoor
Parkour.
Or outdoor parkour one. I'll jump off the building as a final stunt. So she's going to be on, and if anybody else wants to collaborate, Shane, you're always welcome to. Just calling him out. Do I still do Olympic lifting, Sonny? Correct. I do Olympic weightlifting. I'm fortunate enough to have equipment in my garage. Thank you, Farmstrong Athletics. I actually train more now than ever. It's hard to find motivation because I'm not with the great club, but I still do it 5-6 days a week. Energy levels are low at the end of the night because now it's busy at work, and then yesterday, again, knowing when to cut it, I was moving on to squats, and I just felt like I was going to pass out, so I stopped. I did my snatches and cleans and pulls, and I'm like, I'm going to die, so I stopped.
Yeah.
Actually,
If you pass out doing squats by yourself, you could actually die.
I did once. I passed out. As I was passing out, I bracked it, and I fell. And just because I wanted to look cool in front of everybody. So I do Olympic weightlifting. You can reach out to me, Chris, if you want. We're doing a project for people who lift or athletes and trying to do some warm-up programs for them. So if you have any like residual issues from shoulder, hip, knee, ankle, we're trying to design programs for athletes to try to do as per warm-up, and then see how it goes. We're going to try to track improvements. So we're doing I don't know if you can call it a true pilot study, but it's just a clinical, I call it a gangster study because we're clinicians, so we do things a bit differently. Like it's not going to be as rigorous as a scientific study, so we're not going to have a control group because I can't get enough participants. And I'm so picky with research articles, so I'm like, oh man, I want like 10,000 participants. So yeah, if you have any questions for me, Chris, you can always email me. My first name, SUNNY, @pursuitofmotion.com. Or you can actually just message on Instagram. That's probably the easiest. Fastest way to get me. Yeah. So one thing I never had an issue with was my Achilles tendon or gastroc, really, which is nice. I never had, except once. But that was the skin over the Achilles tendon. I was wearing like these new loafers I had.
Oh,
and
yeah.
it was like, oh,
Been there.
I was freaking out. I was squatting, and like my skin was so tight I couldn't actually squat fully. They're currently getting like that right now, so I should probably put some lotion on. Yes, I digress. Thank you, Rob.
Hey, of course.
Appreciate your time.
Thanks for everybody who tuned in. We appreciate your time.
Yes, we do appreciate your time, and the future time givers on YouTube.
Yes.
We appreciate your time too. So let us know if you have any questions. We're gonna leave you to it. Thanks for coming by, and we'll talk to you guys later. Thanks, guys.